Hello, everyone, and welcome. This is Marika from Herasphere, and today I am so excited to be talking to Lily Nichols, aka the Pilates nutritionist. Welcome, Lily.
Thanks for having me.
Thank you for giving me your time. I'm so grateful. Now, what we're going to talk about today is gestational diabetes, and one of the reasons I really wanted to talk about it is I've had quite a few clients recently who've been diagnosed, and along with that diagnosis comes, a lot of emotion, fear, frustration, anxiety about the birth and the rest of the pregnancy. So I just wanted to talk to you a little bit about gestational diabetes and some of the management options. But before we jump in, can you tell us a little bit about your background and your experience with diabetes?
Sure. So I got into gestational diabetes kind of by accident, which is really funny because this has kind of like become the mainstay of my career. But I was working with the state of California. They have a diabetes and pregnancy program. And I worked with them to develop their nutrition and exercise guidelines. And a lot of other states, California, tends to kind of lead the way in progressive medical treatments and approaches. So we had some pretty good guidelines for diagnosing gestational diabetes. I've since gone on to revise, what I now call my real food approach to gestational diabetes based on what I was seeing clinically using those guidelines. But yeah, I was working in the public policy level at the start and then worked clinically with a perinatologist. She's a OBGYN who specializes in high-risk pregnancy and specifically works with gestational diabetes. So pretty much everyone in the area, any of the doctors would refer all their gestational diabetic women to us. And I was the nutritionist that would help them figure out what was going on and explain all the nutrition stuff and do our best to help them manage it naturally.
Yep.
And that's really where I got to sort of fine tune what works and what doesn't work and come up with an approach that can help encourage more women to take the steps to manage it naturally and reduce their chances of requiring insulin or medication to help them do that. So
fair to say a fair amount of experience in the area.
Fair amount, yeah.
That's brilliant. Can we talk a little bit about what gestational diabetes is? Because I think a lot of people are confused as to how it fits in with type 1 and type 2 diabetes. So we could talk a little bit about what gestational diabetes is and perhaps about what, a little bit about blood sugar and insulin and how it all fits in.
Sure, yeah. So gestational diabetes can be defined in a couple different ways. Your main diagnosis or description is that it's diabetes that first develops during pregnancy. Mm-hmm. It can also be diabetes that's first recognized during pregnancy, which kind of opens up this huge can of worms. But essentially, at its core, it is carbohydrate intolerance or insulin resistance is another way of saying it, that we first notice during pregnancy, if I can put it that way. Sure. And that pretty much means that a woman's body is unable to tolerate large amounts of carbohydrates without having high blood sugar levels. Mm-hmm. And some of this is a natural response to pregnancy. Your insulin resistance goes up in response to pregnancy hormones and the weight gain and all these other things that are going on naturally, metabolically, while you're pregnant. And then some of it could be things that you came into pregnancy already experiencing. So we've been seeing a pretty sharp rise in the rates of gestational diabetes. Part of that is with how the diagnosis standards are changing, but we also have a larger number of women coming into pregnancy already with some level of insulin resistance or prediabetes is another way to put it, which only gets more challenging to keep in check the further along you get in your pregnancy. So whether it's started before you were pregnant or developed just as a response to those placental hormones and the weight gain and all that other stuff, we pretty much manage it the same, which is to try to keep your blood sugar as well controlled as we can.
Absolutely. And I guess that actually leads on really well to my next question, because a lot of people sort of ask, well, what have I done to deserve this? Why did I get this? Is this something that I could have avoided? What's your take on that?
Yeah. It's funny, actually. I'm pretty sure if I go back to my book, I think I start with like a why me section, because everyone kind of gets into this place of blaming themselves, and it's kind of a scary diagnosis for a lot of women, especially when it's not well explained, like what's going on in your body and why and whatnot. But yeah, there are some things that can put you at risk for developing gestational diabetes. So I'll go through those. First of all, your weight prior to becoming pregnant is probably the number one factor that can predispose you. So the research estimates about 40% of gestational diabetes can be attributed directly to being overweight or obese prior to becoming pregnant. Again, because that just ups your insulin resistance. Absolutely. So, it's a tough one because I hate to like put the blame on weight. It's such a, challenging topic to broach. And I'm pregnant right now too. So like, believe me, the whole body image thing, all that stuff is really challenging when you're pregnant. So to be like, oh, well, it's because you started your pregnancy overweight. It doesn't put you in a very good place, but it is something to keep in mind if you are in the preconception or fertility stage and you're planning a pregnancy. Keep in mind, it's better to start off your pregnancy at a healthy weight, and that lowers your risk. Another thing is your heritage or ethnic background. So if you are Latino or Native American or Pacific Islander or Asian or Indian or African American, pretty much almost any heritage that's non-Caucasian, you're at a higher risk for developing gestational diabetes, just as those people are also at a higher risk for developing type 2 diabetes. So it shares a lot of the same risk factors. If you have had a large baby previously or unexplained high number of miscarriages or stillbirth or a child with a birth defect, you're also at a higher risk. The idea is you were potentially not diagnosed with the previous pregnancy, and high blood sugar can put you at risk for early miscarriage or some late stillbirth or birth defects or other things during the pregnancy. And then if your mother had it while she was pregnant with you, that can actually play a role in your risk as well, because our pancreas, our organs are actually developing during that period. And if they're exposed to high blood sugar levels, and it can kind of set us up for some difficulty later on in our life.
Well, we like to blame our mums for a lot of things, so we can just add that to the list, can't we? Just kidding. In terms of the diagnosis in America, I mean, I know here in Perth, the ladies will, do a blood test first thing in the morning, a fasting test, and then drink this horrible, gloopy glucose drink, and then they have, I think, 1 and 2 hour interval blood tests. Is that similar in America?
Sort of. It depends on where you go. We in the States are kind of behind in the diagnosis standards. Okay. What Australia is following is what the World Health Organization recommends and what almost every other country follows, which is a 2-hour glucose tolerance test that's done fasting with a 75-gram glucose drink.
That's the glue.
The glucola. And that's actually a very the cutoff criteria for diagnosis with that is pretty stringent, and the states haven't quite gotten around to adopting those guidelines. We have this kind of archaic method where you do 2 glucose tolerance tests. If you fail the first one, then you go on to do another one that is more sugar, but it's not as good at identifying gestational diabetes. It also delays the diagnosis if in fact you do have it, because you have to go back and drink the darn thing again.
At what point in the pregnancy are they having those tests done?
That's usually done between 24 to 28 weeks.
Okay.
There are also some doctors, and maybe they do this in Australia, definitely the progressive OBGYNs in the States do this. They'll diagnose gestational diabetes in the first trimester using a test called the hemoglobin A1C, which measures your average blood sugar over about 2 to 3 months. So if that's high, if you're in the pre-diabetic range, you are considered as having gestational diabetes, and you get, the nutrition education and all that stuff earlier on in your pregnancy, which For someone, it's frustrating. I mean, they're like, oh, I have to keep pricking my finger to check my blood sugar. It's a long time, right? You have like 2/3 instead of 1/3 of your pregnancy to be worried about it. But it really is the proactive thing to do, and we can reduce a lot of complications for baby, and also lower the chances a mom will require medicine if they get early intervention and can manage it, nutritionally and with lifestyle changes.
So would you like to see that become more a gold standard?
Oh, absolutely. Yeah. And, with the California Diabetes and Pregnancy Program, that's written into the guidelines, is to screen all women first trimester with A1C. So the docs who are in the know do that first trimester. That's something that, I had to request from my doctor to see where I was at. And they're like, oh, you're at low risk. And I was like, yeah, but I still want to know. I mean, it's literally a check in the box on when you're already getting your prenatal labs drawn. So you may as well, it doesn't hurt to know.
Just on that topic, there's been quite a few of my clients who have been diagnosed who have been really, really surprised by it, because they weren't in that high risk group necessarily. And they're really surprised when they got their blood test results back. Would you expect women to have any kind of symptoms that they had gestational diabetes, or do you find that that's often a common scenario?
That's a good question. A lot of women feel like you should be able to feel if your blood sugar is too high, right? But not necessarily. The criteria for diagnosing gestational diabetes, like I said, is relatively strict, because blood sugar levels are naturally should be about 20% lower during pregnancy than when you're not pregnant. Your body's like really, really nitpicky about blood sugar levels for very good reason. So they're not going to get to the levels necessarily where you start feeling really awful symptoms or have the typical, the type 1 diabetes symptoms where you're like really thirsty and peeing all the time.
And all you're pregnant anyway. I mean, that's not always a useful symptom to rely on.
So not necessarily, which is why, if you don't do the screening test, it's still a good idea just to check your blood sugar with like a home glucose meter and see where you're at. There's some doctors who are willing to screen with just fasting blood sugar drawn in office, or let you check your blood sugar, with a meter for 2 weeks at home. It's just a good idea to know, because
see where you're at.
Yeah, you don't necessarily have symptoms.
For sure. So once someone's being diagnosed, what's the next port of call? So they'll go into a program with a dietitian and with their obstetrician?
It really depends on the office that they're at. But nutrition is the number one treatment. Most women don't know that. They think that automatically they're going to have to go on medication or insulin, and those are secondary after you've done as much as you can nutritionally, and only needed if your blood sugar is still elevated despite all the changes that you've made. So under ideal circumstances, they would go and see a nutritionist or a dietitian and get some nutrition education. Sadly, I'm finding that a lot of women maybe aren't referred to a nutritionist, or if they are, they're not given very good information. So they're kind of left alone to figure this out and Google their way out of it.
That's where they find you.
Yes, exactly, which is how they find me. It's part of the reason I wrote a book, because the conventional nutrition guidelines are not that great at keeping blood sugar levels under control. And they're missing a lot of nutrients that baby needs to grow in a lot of circumstances. So, it's a tricky one. I've seen quite a few women who are just given a 1-page meal plan with not very great choices on there. Like, we're talking like egg whites in the morning with a piece of toast with margarine and sugar-free jam. Like just not very nutrient dense foods. So some women are just left.
That must make your toes curl when you see that.
Exactly. I call it nutritional malpractice. I just think it's atrocious, the kind of stuff that's given out.
You'd like to think that is hopefully changing pretty rapidly now with, there's so much information that people can access quite easily. And I'm thinking back to my dad has type 2 diabetes, and he saw a dietitian years and years ago. And I was quite surprised by some of the information that he got, because, it was a little bit like, okay, we'll stop eating chocolate and sugar and have some more rice. And it wasn't, I didn't think it was particularly comprehensive and helpful in making sure that he, as you said, got all the nutrients that he needed.
Right.
One of my gestational diabetes clients saw her nutritionist 2 weeks ago, and she learnt so much, because just little things like having cereal for breakfast and turning over that packet and having a look at how much sugar was in that product and how much her body was actually getting from a bowl of cereal and milk. She was really shocked by that. She found it extremely useful to talk through some of those food choices.
Yeah. And that is one of the things that conventional diabetes training does well, is that they do talk about carbohydrates, and they do teach usually carbohydrate counting or carbohydrate portions, and that is very helpful for a lot of women. The challenge is they don't necessarily recommend a level of carbohydrates that's going to keep their blood sugar optimally controlled. So, sometimes they're recommending 45 or 60 grams of carbohydrates per meal. And this isn't a woman who, in the States, failed a 50-gram glucose tolerance test. So it's like...
Doesn't make sense.
Yeah, it's kind of mind-numbing, It's like, okay, well, your body couldn't handle 50 grams of glucose without having high blood sugar.
Yep.
Let's give you 45 or 60 and see how you do, right?
Yeah.
It doesn't make sense, but there's some outdated information on this quote-unquote minimum level of carbohydrates that pregnant women need. I have a whole chapter devoted to why that's bunk, basically. That kind of keeps pushing this relatively high carb diet for pregnant women. And then, of course, we still have the conventional fat is bad for you, saturated fat is bad for you, cholesterol is bad for you thing underlying everything. So women get a lot of mixed messages. They get carbohydrates raise your blood sugar. You have to be careful with how many you eat. But you have to eat
your baby to grow
at the same time, right? And then, okay, you've figured out that carbohydrates are bad but good. Now you also can't have fat. And if you understand how tricky macronutrients are, you get calories from 3 places, right? You have your carbohydrates, your fat, and your protein. If you're going to cut down on one, you have to increase another. It's just, so, and you can only eat so much protein, really. Especially when you're pregnant, a lot of women don't really want to eat quite as much protein as they would before. You have to have some, but at a certain point you max out on protein, and it's a battle between fat and carbohydrates. So if we're anti-fat
and no carbohydrates,
no matter what, you're going to be filling up on more carbohydrates, and as much as nutritionists try to be like, eat more non-starchy vegetables, those are also only so filling. So it puts women in a really tricky position, and I think it's also really confusing. It sends a lot of mixed messages.
So within the advice that you give, what would an average, let's say, meals over the course of a day look like on a Lily plan?
Sure. Well, it depends, honestly, on a woman's carbohydrate tolerance, as we call it, which is how many carbohydrates you can eat without experiencing high blood sugar after your meals, and also whether or not you're on blood sugar lowering medication. So the exact amount of carbohydrates you're going to eat at a meal and exactly what your meal is going to look like will vary. But I will say, like an example of a breakfast, a lot of times the morning is a tricky time to keep blood sugar levels under control during pregnancy. There's a surge in pregnancy hormones combined with a surge in cortisol that makes you more insulin resistant in the morning. So I tend to recommend a fairly low carbohydrate breakfast for most women. So something like eggs and bacon and maybe some sauteed kale or something would be an option, or doing like an omelet with bell peppers and onions and some salsa and avocado. Like that would be an option.
That just sounds amazing. It just sounds lovely. And that's actually an average breakfast in my house is roast vegetables and eggs.
I know. Same
I love
here.
It. And
Same
coconut
here.
milk.
Yeah. And it doesn't have to be eggs, but eggs are just like so
easy,
so nutrient dense and so full of goodness and so wonderful at controlling blood sugar levels that they're like a really good option in the morning. But there's others. And then a lunch and dinner, usually there's snacks throughout the day, and it's just a matter of, not overdoing the carbohydrates and balancing it out with some good protein and fat options. And then lunch and dinner might be something like, I don't know, I can choose like a really healthy one, like maybe 3-4 ounces of wild salmon with a good solid green salad with, I don't know, some pine nuts and goat cheese on it or something, make it fancy. And if a woman can tolerate more carbohydrates, maybe there's some, roasted butternut squash with it, or a small serving of even mashed potatoes might work. I mean, it really is going to depend on the woman, and how large a quantity she can handle is going to depend.
So when you say it depends on how they respond to those carbohydrates, are you getting them to test after the meal?
Yeah, absolutely. Yeah. So you check your blood sugar in the morning before you've eaten anything, and then you also check your blood sugar after each meal. So depending on where a woman's at, what her diet is normally, and if she hasn't been put on medication yet, then I'll kind of choose which level of carbohydrates I want to start her at and then see how she does. And then you can always adjust up or down. Some women will experience high blood sugar just after a certain meal, like a certain time of day. They're more insulin resistant. Like I said, most of the time that's in the morning, but not necessarily. So we can play around with what's going to work at what time of day based on, how her blood sugar is responding. So it's very individualized.
I love that. So as physiotherapists, we're not massively keen on generic one size fits all kind of programs. And I love that you're saying that because obviously by giving everyone exactly the same diet, the same A4 sheet of information, we're not going to have anywhere near the same results as something that is specifically designed for you, and because your body's going to react differently to sugar than someone else with gestational diabetes.
Exactly. Yeah. So you start with a general idea and some basic nutritional, just how your body responds to different foods and combinations of foods and amounts, and then you customize from there. There's no reason that women need to feel like they have to either stuff themselves silly to meet some minimum servings of whatnot, or starve themselves because they've been given some super low-fat plan that leaves them really hungry. There's a happy medium somewhere.
Yeah, and you have to eat. We still have to eat, and we get a list of every single thing we are not allowed to eat. It doesn't feel very inspiring for cooking, does it?
Right.
Now, if we talk about the effects of gestational diabetes, so if someone is having really good management of gestational diabetes, then presumably the effect on the mum and the baby are fairly minimal. Is that fair to say?
Yeah, if your blood sugar remains well controlled, you're actually at no higher risk for complications whatsoever, even with a gestational diabetes diagnosis.
Okay, so for those that are less well controlled, what can be some of the effects on mum and baby?
Yeah, well, some of the biggest ones, well, I'll talk about mom first because I always talk about baby and then I forget about mom. But blood sugar levels do affect other systems of the body. So you're more likely to have swelling if your blood sugar is very high. You're more likely to develop preeclampsia if you have gestational diabetes. And then post-delivery, there's a higher chance that you will develop type 2 diabetes later in your life. So it's a good idea to get those blood sugar levels under control, and also to understand how food uniquely affects your blood sugar, because that's something you can carry with you for the rest of your life to lower your chances of getting type 2 diabetes. For the baby, the risks kind of depend on how high the blood sugar is with the mom and at what point in the pregnancy the blood sugar is high. So for example, for women that come into pregnancy already with high blood sugar, and this is most particularly like undiagnosed type 2 diabetes, there's a pretty high chance of developing birth defects or actually miscarrying the baby because blood sugar beyond a certain threshold is actually considered a teratogen, or something that causes directly birth defects, which most people don't know. They think it's like, oh, it's just sugar, no big deal. That's kind of a big deal. Their bodies are so particular about it. Sometimes, again, when blood sugar levels are really, really high, there's a higher chance of stillbirth. And that can happen with gestational diabetes, particularly towards the latter stages in pregnancy. Some of the other ones are going to be underdeveloped lungs. So the high blood sugar levels can interfere with lung development. They can change the baby's pancreas. And so basically, if a woman has high blood sugar, that sugar is going to be transferred to her baby. And at a certain point in development, when the baby starts producing its own insulin, it will take over the job of keeping the blood sugar under control, and will have elevated insulin levels to manage its blood sugar.
So the little baby pancreas is going nuts.
Yeah. So the baby's pancreas gets super hyperstimulated, which can cause the baby to put on an excessive amount of weight, particularly fat in the midsection. It can also cause the shoulders to grow disproportionately large, which can up the chances of them having shoulder dystocia during delivery, so getting stuck during delivery, or potentially, I think this is less common because a lot of shoulder dystocia is just, how good your birthing people are, but potentially, like, the baby can be too big that you can't birth, or you can't birth the baby safely, and that's why sometimes women are pushed to have a C-section if the doctor suspects the baby's large.
Do you find that women are encouraged, sorry, just to interrupt, do you find that women are encouraged to be induced a little bit earlier because of the risks associated with a larger baby and potential dystocia?
Yes, and the risk of stillbirth, yes, which is frustrating if you're within the subgroup of women who is really proactive about your blood sugar and you've been keeping it at normal levels. Like I've said, that you have no higher risk of any of these problems if your blood sugar is normal, and yet some doctors will still push these extra interventions for delivery, despite there not really being very good evidence to do so. So doctors usually, they hear gestational diabetes and they immediately go to worst case scenario, and sometimes, in my opinion, I think they overreact and sometimes over-treat or over-intervene with delivery options, which is really unfortunate. However, we do want to be aware that there are risks. One of the other things with a baby that relates directly to the insulin levels is if the baby's insulin levels are very high and you deliver the baby, quite literally you cut the cord, and that constant supply of sugar disappears. And takes a while for breast milk to come in. The first milk is not very high in sugar. The colostrum is much higher in fat and protein. The baby still has really high levels of insulin, and they can bottom out. And they can go hypoglycemic, which is actually a very serious medical emergency. Like your baby can die, and sometimes they require a stay in the neonatal intensive care unit. Sometimes that'll require them to have some sort of supplementation before your milk comes in. Now more doctors are willing to do a little more skin to skin and early initiation of breastfeeding. But if it's really, really low, sometimes it can be a big risk factor. And then the final thing that I'll mention, because I'm just going into all this detail, is that
no, it's great. Thank you.
Like I said, the pancreas of the baby is affected on like your genes, the baby's genes are actually affected by the high blood sugar, and specifically with the changes in the pancreas, the baby's now at a higher risk for developing type 2 diabetes and metabolic syndrome, becoming overweight or obese during their lifetime, because of that early exposure.
Yeah.
So that's pretty scary. It's like I think by the time a kid is, entering puberty, there's a 6-fold higher chance that they'll develop type 2 diabetes if the mom, again, had uncontrolled gestational diabetes. So this is why the doctors are so annoyingly particular about your blood sugar levels.
Yeah. There's good reasoning for it.
Yeah, there's a reason.
And Lily, if we look at, I think I had read somewhere that that women who have gestational diabetes are something like 7 times more likely to have type 2 diabetes later in life. We may not have the research yet with this, but those women who are really well controlled and, say, for instance, going through this program of really, really good intervention from a dietitian who keep their blood sugars under control through pregnancy, are they still in that really, really high risk group? Or do we not know that
we
yet?
don't have perfect data on that specifically, because I feel like there's 2 subtypes of women who get gestational diabetes, if I can just kind of simplify it.
Yeah.
You have the women who come into pregnancy already pre-diabetic or potentially undiagnosed type 2 diabetes, or maybe they come into the pregnancy fairly overweight, and then are for whatever reason don't lose the weight post-pregnancy, or they manage their blood sugar during pregnancy and then revert back to all of their usual
lifestyle.
habits. So lots of sugar, and not like, oh, it's just something that happens during pregnancy and then it's done, right? That's how a lot of women feel, especially if they're given like a super starvation, tasteless, low-fat diet, might I add. So if they don't really get very good information and very tasty nutrition advice, why would they continue, right?
Yeah.
Those women definitely are in that subcategory of being at a higher risk for getting type 2 diabetes. For the moms where it just develops during pregnancy, meaning you came into pregnancy with great blood sugar, and this is something we'd be able to see with A1C if they tested this, right?
Yeah.
And then, I lost my little earbud. And then you go through the pregnancy, the placental hormones, the weight gain, all the stuff with pregnancy causes your blood sugar to surge, and it truly is just a gestational thing. And then you drop back down to your normal weight postpartum, you breastfeed, you continue to eat well. Those women, I think, are at a much lower chance of getting type 2 diabetes. And I like to say, it's not fate or destiny that you will get type 2 diabetes. I mean, the stats are kind of scary. It's like within 5 to 10 years of delivery, there's a 70%, up to 70% chance you can get type 2 diabetes. So those are scary stats.
That's still pretty young, isn't it?
Yeah. However, there's a lot you can do to prevent that. And I think as long as we're giving women the information to be proactive, and particularly if they're able to come down to a healthy weight within about a year or so postpartum, if they breastfeed, that lowers their chances significantly. And if they just lay off the really refined processed carbohydrates and sugars, which plays directly into your weight and your insulin resistance and all that stuff, your risk is going way, 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 way down.
You're giving yourself a chance, aren't you?
Yeah.
Where does exercise fit into management of gestational diabetes?
Pretty much right alongside the nutrition. So exercise is great during pregnancy, particularly because when it comes to gestational diabetes, it helps to keep the blood sugar under control. So when we think of how our body manages blood sugar, we think, okay, blood sugar goes up, our body releases insulin, insulin makes the blood sugar come down, which is part of it. The other part of it is we have some glucose receptors, things that pull glucose or blood sugar out of your bloodstream, that are activated by non-insulin factors. And one of those is exercise. So you move your muscles, they take up sugar out of your bloodstream. And just over the long term, especially strength exercise helps to reduce insulin resistance as a whole. So Yep, exercise is fantastic. And for women who have not been diagnosed or maybe aren't even pregnant yet and are thinking of could they do anything to lower their chances of getting gestational diabetes, we know that moms who exercise for even just 30 minutes, 2 to 3 times a week before pregnancy and then during their pregnancy, they lower their chances of developing gestational diabetes up to 76%. So it's like,
oh, brilliant.
Like we have really good data supporting the benefits of exercise in pregnancy.
Fantastic. And interestingly, I find that the focus tends to be so much on diet with gestational diabetes that we don't actually hear that much. I mean, we know in their recommendations that they say that, it helps with gestational diabetes, but I don't often see the emphasis on exercise anywhere near as much as diet. So I'm glad you say that as a fellow Pilates instructor and exercise instructor.
Right, especially. Yeah, and I've worked with a lot of pregnant women too and women postpartum, so I know how hugely important exercise is in preparing and dealing with all the changes that your body goes through during pregnancy, just as just from a level of like keeping you feeling well and mobile, it's so important. But then for these carryover effects and benefits for your metabolism, even more so. I would say, food definitely is going to be the number one factor. Mm-hmm. Like you can't out exercise a bad diet, so I like to keep that in mind, but absolutely exercise is like the forgotten medicine. And I think a lot of obstetricians are, maybe they're not super familiar with what types of exercises are safe during pregnancy, but all the major organizations, say that exercise, unless there's contraindications, exercise is safe during pregnancy. Most organizations recommend 30 minutes a day at minimum. So,
I think statistically it's something like 80 to 90% of pregnant women do not meet the current minimum recommendations for exercise in pregnancy. So, we know the majority of people are not getting anywhere near as much exercise as
absolutely.
They can do. Yeah, for sure.
Absolutely.
Now, I realize that I'm taking a lot of your time here, Lily, so I'm just going to ask you one more thing.
Sure.
I really want to just talk a little bit about what you've been up to in terms of your online program. I know you do a lot of one-on-one treating with people in person. So can you talk a little bit about, what you've been up to and what you're currently offering for people?
Sure. Well, there's 3 ways to get more information about gestational diabetes. Maybe 4 ways actually. I have a 3-part free video series on my gestational diabetes specific website. I have 2 websites, so
I'm going to put the links online.
So Pilates Nutritionist is the main blog. My gestational diabetes site is realfood4gd.com. So there's a free 3-part video series that kind of walks you through some of the basics about gestational diabetes so you can get started and see how a real food approach might work for you. I also have a book, so it's all the same name. Keep it really simple. So some women, will like to do the DIY thing and figure it out on their own. So the book is a great option. Quite a few healthcare practitioners also use it. It's pretty heavily cited with the research, since what I recommend isn't the norm yet.
Yeah. You're hoping to change some minds.
Exactly. There's actually, I have a couple research studies underway that are using my approach. So, we'll see the guidelines shift over time, but it's going to take some time.
Yeah.
And I also have an online program, the Real Food for Gestational Diabetes course. And that is a really great way to delve much more into detail than the book goes into, especially if you are a person who learns better from video or learn better in a group format. We have a support group that goes along with it. I jump in the Facebook group for office hours too to answer personal questions. So it's kind of a really packed course. I have some advanced training in there. That's not information that's not in the book. I have specifically, there's a really good training on how to lower your fasting blood sugar naturally, which is the first morning blood sugar. That's the trickiest one to change just with diet and lifestyle, and very few healthcare professionals even give that option. They just go directly to medication. But we have women who've taken the course who've had, sometimes 1 or 2 previous pregnancies where they required medication, and they were able to manage their blood sugar 100% naturally, normal pregnancies,
Wow.
healthy, normal babies, no complications whatsoever, right? So it's definitely possible with really good information.
So that course is very much designed to empower women to help themselves through that process. So you're giving them all the information.
Exactly.
They can liaise with their local GP or whatever to have, monitoring.
Yeah. So I'm obviously not a replacement for a doctor, but oftentimes I do fill in the gaps from either the nutrition education they got that wasn't very good, or the absolute lack of information they got about how to manage it on their own. Gosh, I recorded some prenatal exercise videos. So there's you can see me with my little bump doing some Pilates stuff. It's really good. And it's really fantastic to have the community that goes with it, because like I say, I mean, it's rare to have a woman, be pregnant right alongside her best friend. Even more rare that you even know somebody who has gestational diabetes.
Yeah, absolutely.
Very lonely, very isolating, very confusing. And so it's really nice to have other women in there to bounce ideas off of.
Share recipes.
Other than the course, I do, help women one-on-one as well. I tend to be directing women more to the course because there's just so much that's covered. There's like over 20 video lessons in there. So it really, is money-wise and a bang for your buck, and information-wise, you get so much in the course, but I do still have some one-on-one clients as well.
Brilliant. And is the course that's through the Real Food for Gestational Diabetes website?
Yep.
So realfoodforgd.com.
Exactly.
Brilliant. Excellent. I think I've asked all the questions that I wanted to ask. I'm just having a quick note there. We've, I think we've covered all the things that I wanted to. Is there anything else that you wanted to pop in there, Lily?
Oh gosh. I feel like we covered it all. If I can end with anything, I would say, if you are diagnosed with gestational diabetes, like, let yourself have this time to mourn the loss of unlimited cookies and whatever, right? But it's not, it's not a death sentence by any means. For a lot of women, it's kind of a blessing in disguise. There's usually a silver lining to it. A lot of moms feel like, if I hadn't had this diagnosis, I wouldn't have been as careful about eating really good foods for my baby. Or I wouldn't have known that I have this blood sugar issue, and now for the rest of my life, I'm aware of this and I'm going to be proactive about it. I had no idea that this food would raise my blood sugar so much. And now that I know how foods affect me, like, I'm never going back to cereal in the morning again. These are usually good things. Like, sometimes, you need a little kick in the pants to develop healthy habits, and pregnant moms are the most motivated group of women.
Absolutely.
Motivated group of people, period, because they know how much things are affecting their baby. And hey, if some of those things happen to carry over into your life long term, more power to you. So it's not necessarily a bad thing. And like I said, with the right information and support, you can still have a super healthy, normal pregnancy, maybe even a healthier pregnancy because you got this information. So don't get too down on it.
No, I think that's brilliant. I think a lot of people would take out of this the fact that, you're inspiring women in that you can give them some choices, some options, some ways that they can help manage their own health. That is, like you said, not just cutting out tons and tons of food. It's giving you lots of really, really nutritious choices and exercise choices, and learning about your body, which is fantastic. So I'll wrap it up there. Thank you so much, Lily.
Thank you.
And I'll put all the links below on the website. Thank you.
Great. Thanks.
Recording.